Okay, dear friends, welcome. I'm Martin Tomeček from Prague, Czech Republic. It's my pleasure to meet you and share my case, at least at this way, as we cannot meet actually for quite a long time. All conferences were cancelled. Unfortunately, we could not meet in Korea, we could not meet in Rome as it was planned for the last year. So at least in this way we can discuss and share the knowledge and experiences on the internet. In my presentation I prepared a video of a case of a young lady. She was having a horizontal bone defect in her upper canine area. This lady was actually undergoing the complex reconstruction, including the orthodontic treatment. And after the orthodontic treatment, and where the orthodontist opened the gap for missing upper left canine, we had a surgical goal to increase the amount of the bone, because as you can see at the sectional CBCT X-ray, we didn't have really enough bone for placing the implant. Fortunately, the vertical dimension of the bone was pretty good, but still the horizontal was insufficient. Usually in these situations we can use the quite simple way of collagen membrane fixation, but still in the upper jaw, in the front area, I sometimes prefer to use a form stable membrane, including the titanium reinforced membranes like the Wi-Fi membrane. Here, after the wound opening and approaching the bone, we clean the bone surface. Normally I use the periosteal elevator, or which still leaves some few remnants of the fibrous tissue. So that's why I prefer to use also the bone scraper, which is primarily aimed for the bone chips harvesting, but we can also nicely use it for cleaning the bone surface from the remnants of the periosteum. Now, just the first stop, let's talk a little bit more in detail about the flap elevation. As you probably noticed, I did only one releasing flap on the distal aspect of the wound closure, of the wound. Why is that? What is the main goal of the flap elevation? The goal is to gain a nice, convenient approach to the wound. Namely at the frontal area, we do not automatically do a mesial releasing incision, because there is still kind of risk of a scar formation or a gum recession. So whenever it is possible, we prefer to do only one side flap releasing incision. The other question is, how far should we elevate the periosteal flap? The range of the flap elevation is namely involved by the need of the bone augmentation. So when we will later on discuss how can we really activate the flap to achieve a primary closure of the wound, the periosteal elevation is not that much influenced by the range of the flap activation, but the range of the bone augmentation. That's the first stop in detail. Secondly, after achieving a good approach to the wound, to the bone defect, we have to prepare the bed for we have to prepare the bed for the bone. So the cortical bone, as it is almost a vascular tissue, we use a trephine burr to bring the blood into the particulated bone graft. When this is done, we adjust the shape of the Wi-Fi membrane. The Wi-Fi membrane, it's easy to cut outside the mouth, and we should gain the shape of the membrane so it does not disturb the surrounding tissues. It covers ideally and overranges like 2-3 millimeters, overranges the range of the particulated bone graft. Very important thing is the membrane, as it is completely occlusive. That means that it does not allow any angiogenesis or transvascularization through the layer of the membrane. We still have to allow the vessels to connect the superficial soft tissue cover and the underlying healthy and vascularized tissues. That means the bone crest and the ridge or the rim of the tissues around the teeth. So that's why we have to cut the membrane in that way that approximately 2-3 millimeters of the bone around the teeth should be uncovered, should stay uncovered. When this is done, we can form actually the membrane. So that's the main advantage of the titanium reinforced membranes. We can shape it outside the wound and achieve a nice stability for the membrane. Still, it should be, or it must be, firmly attached to the underlying bone. It's really my recommendation. The problem if the membrane is not attached to the underlying bone is that it still can tend to reopen, and even the small pressure of the sharp edges of the membrane can lead to the disruption of the soft tissues covering the wound. Here, as I noticed during the surgical procedure, I did not have really a convenient and completely free of stress-free approach to the bone. So that's why during the surgery I decided to add the releasing incision even on the mesial aspect of the wound. We should always prefer to have a nice approach to the wound rather than traumatizing the wound and the flaps with the manipulation during the procedure. Here I'm preparing my mixture of the particulated bone, so I always use autogenous bone harvested mostly from the rim of the lower jaw, as it was done in this case, and it's half to half mixed with the xenograft and also mixed with the antibiotics and the blood. So altogether I have my bone substitute. As you can see, being placed on the top of the bone defect. When it is moistured, we can handle it quite easily with tweezers and place it nicely. Abundant volume of a particulated bone graft on the top of the bone defect. A very good advantage of using of the form-stable membrane is that as we gain a very good stability of the particulated graft, we also have a less shrinkage of the volume of the graft material during the healing period. When we use the collagen membrane to cover and stabilize the bone, we usually have some kind of shrinkage of the volume. Whereas when we use this reinforced stable membrane, the shrinkage is almost zero. So, as you will see later on in this video, because we will see the results of this augmentation, we have almost no shrinkage of the augmented bone. Here we are using the titanium pins for fixation the membrane on the apical aspect of the grafted area, which is important so the particulated bone does not spread more apically when it's closed, when the wound is closed, nor even later during the healing period. As I said, it's really important to attach firmly the edges of the membrane to the surface of the bone. If we leave the membrane free to move, it could tend to open, to relax and open and rise against the soft tissues covering the wound, and that can really lead to complications where the sharp edge of the membrane can cut through the soft tissues and come out to the mouth. That can be solved by reopening the wound and early removal of the membrane, but still the goal is to close and secure the membrane in that way that it can really stay in the wound through the whole period of bone healing. Now, because we can have some imperfection of the fit of the membrane, we pack the contents of the particulated bone graft into under the membrane and secure its stability. Now we come to a very important part of the soft tissue management. After the package or after the closure of the bone graft, we need to reliably close the wound with the soft tissue flap. And actually this flap activation has two parts. The first part is the periosteal incision. So the question is, where is the right place of the periosteal incision? And I mention that because very often the surgeons do the mistakes, and the incision is done too deep alongside the bone crest. So I would like to bring up that the correct placement of the periosteal incision is not really deep down to the elevation of the periosteum. Despite that the periosteum was released in the large area, we still place the periosteal incision related to the position of mucogingival junction. So the right placement of the incision is something like 2-3 millimeters below the mucogingival junction, not necessarily farther and deeper, closer to the bone. What happens if we place the incision too deep? If we place it too deep, then we may just harm the muscles and deep tissues, which leads to the profound swelling of the tissues, which will even worsen the stress of the wound closure. So it's really important. We do not need to make the incision too deep. How can we achieve that? Of course we can use the blade, but what is really safe is using of the scissors. So as you can see, with one hand we stretch the flap with the tweezers, and with the other hand, using the scissors, we open the epsilon-like part where the periosteum and mucosa detaches. So in that part we can see very nicely where is the right place of the incision through the periosteum. It's, as I said, it's 2-3 millimeters below the mucogingival junction. Then I put one of the blades of my scissors into the gap, because I can clearly identify the periosteum here, and step by step I continue with releasing or cutting the periosteum. In this way I go alongside the wall flap, so I really do not leave any part of the periosteum undetached. The next step is the flap release, because even though we gain quite a nice release of the flap just by cutting the periosteum, we still have to release the flap from the underlying tissues. And now the question is, where is the correct layer where we could detach the flap from the underlying tissues? And basically the correct position is the constant depth under the mucosa. Very often the surgeons do the mistake, they go too deep, again more alongside the bone, underneath the muscles and fibrous tissue or adipose tissue. Why is that wrong? It's wrong because if we do that, then we just leave all the bulk of the soft tissues attached to the flap, which should be released, which should be free of stress. If we cut alongside the bone, we leave all this bulky tissue attached to the flap, and as it's swollen, as it gets swollen during the post-operative period, it just pulls the flap down and brings a lot of stress to the wound that could lead to the further complications like a wound exposure and a secondary intention healing. So this is really important part of the flap activation. Again, we can use scissors. As you can see, I'm using my tweezers to stretch the flap, and again with the scissors I can detach and relax the rare fibrous tissue, rare connective tissue under the mucosa. And you can see that all the muscles and all the mass of the tissue stays attached to the bone, it stays attached to the periosteum. And what makes the flap really flexible and free of stress is its constant thickness as it is activated. The bigger release of flap I need, the farther from the wound I go, but still in the constant depth from the surface, superficial layer or superficial part of my flap. And now we are going to close the wound with our sutures. We always do 2 sutures. First, we use the horizontal mattress suture to close, to bring the flap together, to bring the margins of the flap together. This is really important, because this horizontal mattress suture will hold the stress, and it will really face the stress and swelling of the wound during the healing period. And after that, we do the single sutures, edge-to-edge sutures, which will secure the perfect seal of the wound. So whereas the horizontal mattress sutures are important to face the stress of the swelling, the single sutures are important to secure the perfect seal of the inner part of the wound. Here it is really important to place the single suture right at the end of the releasing incision. Sometimes we can think that it's easy or it's stable enough, but from my personal experience, I know that it's really important to place the very most apical suture, as you can see here, right at the edge or right at the ends of the releasing incision. And then after several months, as you can see here, when we reopen, we have very small shrinkage of the bone, of the particulated bone. We just remove the membrane. If necessary, we can again do the releasing incisions. If not, we can remove the membrane without any releasing incisions. Thank you very much for your attention. I hope you enjoyed. I hope that you have some information regarding the technique and use of the Wi-Fi membrane, and wish you a lot of fun with the surgical reconstructions.